Good afternoon or good morning, everybody. Send us a chat and let us know that you hear us. And I am so excited to be with you, but I wish it was in a different format. I am not in the Arizona desert, and that's where I wish that I was. So thank you for your patience with this, and thank you for choosing the hybrid form of giving you this information. And, you know, we can talk about the exam at another time, but I think the hybrid is a really good format for you, because what I'd like for you to do is go through the information, you know, over the next 2 days, and you're going to have a whole nother viewing that you can use at a later time. So welcome to the hybrid review, and welcome to this version of it. There are a couple of people that I want to introduce you to, and I don't think that you're going to know either one of them, but they're very important people for our communication. So the first person I want to introduce you to is Dr. Mimi Secor, and Mimi is joining us from Cape Cod, Massachusetts.
Yep.
And Mimi, I thank you for being with us today. Mimi, as you know, has been an NP for many, many decades. And when I tell you how long she's been an NP, you probably won't believe it. But she's been an NP for 43 years. And while she's a family nurse practitioner, she's worked in all kinds of different areas. And I think her real love is women's health. And so she's going to do the women's health part of this for you, and you'll get to know her very well. And she's just somebody who's very near and dear to me. But Mimi, thank you for being with us.
Thank you, Amelie. I'm thrilled to be here.
All righty. The other person that you need to know about for this webinar is Dr. Kathy Ballridge. Dr. Kathy Ballridge is a family nurse practitioner in central Louisiana, and she's going to serve as the moderator for our sessions. And Kathy also works for APEA as our director of psychometric analysis, which we can talk a little bit more about when our subject of testing comes up. But anyway, these are the two people that are going to be with me on these conversations with you. And I want you to feel very, very comfortable in sending over questions, because we really want to be able to reach out to you. I guess the other thing I want you to know before we formally begin to take some questions is that while I may be separated from you by miles and distance, I want you to feel like I am right here with you. And not just me, but Mimi and also Kathy.
Exactly.
We are going to be part of the people who are going to help you get this and make this like a live experience for you. So don't hesitate to ask us a question. And I'd like to get going. Kathy, has anybody sent over questions yet?
I don't have any questions yet, but
Okay.
Let me just give them a little bit of instruction so that we'll know how to use this. I think they're figuring out how to use the chat function, because I see a lot of those chats coming through, and that's great. You can chat with each other. You can chat with us personally. Make sure that, like it says here, that if you want to send a chat to everyone, that all panelists and attendees is selected, and that way everyone can see your chat. And as always in a classroom, we tell you that if you have a question, make sure and ask that question. Don't hold it back, because somebody else has that question in mind as well. And so when you're asking that question, it's helping somebody else that may not be ready to ask the question. So just a little bit of information. You're considered an attendee, and welcome. We're so glad you're here. You're automatically muted, and your video is automatically disabled upon entry into the Zoom. So you won't be able to unmute yourself, and you won't be able to show your picture, which may be a good thing. It is for me a lot of times. And so we're your panelists, and obviously you can see us and hopefully can hear us very well. Use the chat feature if you do want to chat with other attendees and panelists. You can send private messages as well if you'd like, but we prefer that you keep those open to everyone. We do have some APEA support folks that are on with us as well, and they'll be responding if you have a general question about anything. They'll be on the chat and they can respond to some of those for you. If you have a question for Dr. Amelie or Dr. Mimi, use the Q&A function. So at the bottom of your screen, you can mouse over it, and a little box will come up with various things, and one of them is a Q&A. So you click on that Q&A and you type your question. And once the question comes through, I'll be moderating that. And so I will pose the question to Dr. Amelie and Dr. Mimi, and they will answer the question verbally so that you can hear the response as well as everyone else. So those are your instructions, and we are here for you to answer whatever questions you may have.
All right. Well, sometimes it takes a little bit to kind of break the ice. And, you know, I've watched my clock all morning long thinking about you viewing the videos. And at about 8:30 my time, I'm in Central Time Zone, I looked at my watch and I thought, they haven't viewed video yet, or pulmonary. And then as the morning has gone by for me in my time zone, I realized, okay, they're viewing pulmonary right now. And so I guess you've gotten through that. If we don't have any questions, I'm going to kind of initiate what I would really like to tell you if I was there with you. And as you got through pulmonary this morning, at the very end, there's something that I call an exam checklist. And the exam checklist is going to be very, very important for you. On the left of the exam checklist are going to be different diagnoses in the realm of pulmonary. And then on the right side of the checklist is something that you need to know about each diagnosis. Let me show you what I'm talking about. So the first diagnosis on your exam checklist is acute bronchitis. And then on the right side, if you want to make sure that you're exam ready, when you look at acute bronchitis, what you ought to know is everything on the right side. For example, acute bronchitis, you ought to know the clinical presentation. The thing that brings these people in, as you know, is that they cough and they cough and they cough. So you got to know what brings them in, both the subjective and the objective findings. The next thing you need to know about acute bronchitis is how to diagnose it. Well, we don't need a chest x-ray. Acute bronchitis is typically diagnosed on clinical presentation. So if the exam were to ask you a question about how to diagnose acute bronchitis, remember to pay attention to things that are quick, cheap, non-invasive, and you can do it in your exam room. So for acute bronchitis, it's not going to be to get a chest x-ray. It's going to be to diagnose them on clinical presentation. For acute bronchitis, the next thing you need to be able to do is to know what's in your differential. And if you looked at the video already, you know that pneumonia ought to be one of those things that you consider. So that's how you answer that. As far as farm management, from the video, you probably didn't hear me talk about any medications to treat acute bronchitis because we don't give them. And the reason we don't give medications for acute bronchitis is simply because they don't shorten the severity or duration of acute bronchitis. You know, I like to pull on what Dr. Mimi says. One of her favorite expressions, meaning when you have to be patient as a patient, is tincture of time. Time is what helps people who have acute bronchitis. So as far as farm management, no meds usually, but non-farm management, remember Dr. Mimi's tincture of time. And then follow-up care. Like, do you need to follow them up in 3 days? No, it's a viral infection. It's going to run its course. The next thing you need to be able to do with regard to acute bronchitis is to recognize a normal course. And the example I like to give is, suppose you diagnose somebody a week ago with acute bronchitis, and they call your office and they say, hey, Amelie, you diagnosed me with acute bronchitis a week ago. I'm still coughing. Is that part of the normal course or is that a complication? Well, it's a normal course. And how long, if you remember from the video, how long do people cough when they have acute bronchitis? It's up to 21 days, up to 3 weeks. So not real abnormal if they call you. That's a normal course in a week. And then finally, the last part of your dissecting these diseases with acute bronchitis is to recognize any complications. And the example I usually give is, you diagnose somebody with acute bronchitis 3 days ago, and they call your office today and they say, Amelie, you diagnosed me 3 days ago with acute bronchitis. Today I started running fever. Is that normal or is it a complication? I think it's probably a complication. And I bet you do too if you listen to the video. What complication are you thinking about? Because I'm thinking about pneumonia. So for every one of those diagnoses on the left, you should know the clinical presentation, know how to diagnose it, know what's in your differential, know how to manage the form and non-form, any follow-up care, recognize the normal course, and any complications.
So Dr. Amelie,
Yes.
I was still sharing my screen, and so your screen was not showing. I am so sorry.
That's okay.
So, yeah,
Go
it
ahead
just
and
dawned
share
on
your
me.
screen, Kathy.
I stopped sharing my screen, so you can share yours.
All right. Well, I was going to pull up my exam checklist. Can you see it now?
No.
No. Well,
See if I
Kathy,
can.
go ahead and share your screen with them so there'll be something up there.
Okay.
And I've
And we do have a few questions that are ready for you.
sure. Let's get the first one.
All right. This is from Beverly. She
Okay.
said, in the pulmonary section, low dose CT for lung cancer screening, is it with contrast or without contrast?
It's without contrast. And that is a great question because, you know, screening saves lives. And I had somebody just a few weeks ago who got the regular low dose CT, no contrast, and was found to have a stage 1 lung cancer. She's already been treated with radiation and is doing very, very well. So I guess, you know, the take home point about that is that it saves lives. So no contrast dye. And we're going to talk about contrast a little bit later today in the neuro section. So make sure that you're listening for that when we get to it. What other questions do you have, Kathy?
So this is a multiple part question.
Okay.
I'm going to read it all through. And if you need me to repeat it, I'll be happy to do that.
I may
so
do
this
that.
is from Megan.
Okay.
Megan,
Hi, Megan.
says, can you please review the CAP treatment guidelines? You mentioned that the guidelines might change soon. What are the changes and where can we find the specific guidelines that we will be tested on?
Okay, perfect. Megan, that's a great question because as you begin to kind of focus your brain and shape your brain around preparing for this exam, you always have to remember that the exam is going to be about 1.5 years to 2 years old when you get it. So knowing the latest, greatest information will not always be a great benefit to you. And a perfect example is the question you just asked about. In December, just 3 months ago, we got brand new guidelines for treatment of community-acquired pneumonia. Some things changed, but the majority of the things that we use to treat community-acquired pneumonia did not change at all. And when we think about treatment of community-acquired pneumonia, I want you to rely on the guidelines that you probably learned in school. They're exactly what I gave you today. Believe it or not, the guidelines for treatment of community-acquired pneumonia were given to us in 2007. And every year they were reviewed and found to be recent and up to date. The change that occurred in December is not going to affect any way that you answered on your exam, because the changes really were in a couple of things. One was in drug treatment. The addition was to give high dose amoxicillin. And I know that you're not going to see a question about that on your exam because it's too new. As I said, it takes about 1.5 years or even 2 years to get a new question and make it reliable and valid. And it's just too new. So the guidelines that you should know are if populations have comorbidities, like they're older, they're immunocompromised, they have multiple comorbidities. Those are the patients that when you reach for an antibiotic on your exam and in your clinical practice, you reach for a respiratory quinolone because they have comorbidities present. When patients don't have comorbidities, for example, they're young, healthy, and non-smoker, but they just happen to have pneumonia, we usually think about treating them with either a macrolide or doxycycline. That's how you answer it on your exam. The new addition was amoxicillin, too new to be on your exam. So I hope that hits it. Kathy, does it sound like I addressed her questions?
I think you did. Those were the
Okay.
changes, and you probably won't be tested on those for a little while out.
Yeah.
So
No, even if you take the exam next year in 2021, you're not going to be tested on the new addition of amoxicillin for a healthy population. It's just too new to be on your exam. So hopefully that allays your fears a little bit, Megan.
Great. Thank you, Dr. Amelie. So we do have another. This is from Sarah.
Okay.
Sarah said, what are your thoughts about those who are penicillin allergic, who, when having to choose 2 antibiotics to treat community-acquired pneumonia?
That's a great question. And you know what I have to say, Sarah? I can already tell that you're critically thinking because you're trying to go to option or plan B if plan A is not good. Great critical thinking. So here's what I would tell you. If you have a penicillin allergy and it's a true penicillin allergy, it means that when you have to give 2 antibiotics to treat the patient, you're not going to be able to give a penicillin or a cephalosporin. I think if you look at the new guidelines and the old ones, they're going to say, go first with a respiratory quinolone. And that would be my recommendation to you. If you can't go with a respiratory quinolone and you're pen allergic, I would have to scratch my head on that one, really. I would probably give you some doxycycline. I would even consider, I know what I would do. If I couldn't give you a respiratory quinolone, and I really think you had drug-resistant strep pneumo, which is the reason you give a respiratory quinolone, and you're allergic to penicillin, my third choice would be to give you clindamycin, because clindamycin has excellent strep pneumo coverage, and while it's not the easiest antibiotic on your GI tract, that's what I would give. And if that didn't do it, you know, I don't know. I'd have to scratch my head, but that's a really good question. I'm very impressed with your critical thinking ability, Sarah.
Thank you, Sarah, for asking the question. Okay, and here's one from Jamie. She said, is there a specific respiratory quinolone that is best for patients with comorbidities?
You know, there are 3 respiratory quinolones, and we just got a 4th one called Baxdela, but that's too new to be on your exam. So we have 3 respiratory quinolones, meaning those quinolones kill bugs above the belt. All right, that's what respiratory means in front of quinolone. So the 3 quinolones that we usually see with in use for pneumonia because they're respiratory quinolones are things like Levaquin, and that one is generic. So you'll see a lot of people pulling and reaching for Levaquin. It's also the one that we know the most about because it's been out the longest of the 3 respiratory quinolones. The other 2 respiratory quinolones are moxifloxacin, which is Avelox, and the other one is Factive, which is gemifloxacin. I mentioned Baxdela, too new to be on your exam, but I would imagine that if you see a quinolone on your exam, and I think you will, that levofloxacin will be the one just because it's older, and as you may know, and if you didn't, you know now, your exam typically gives you older medications. So they don't give you brand new, latest medications. They give you, you know, old ones. So old, tried and true. And by the way, while we're talking about that, on your exam, you should expect both brand and generic. So I know for a lot of people, you're breathing a sigh of relief, but on your exam, expect both brand and generic when you see a medication.
So we have another question. She asked it in the chat, and I'm going to do my best to decipher that. It's
Okay.
from Mary.
All right, Mary.
Mary says, what's the difference between symptom-driven ICS? I'm assuming that's
Probably an inhaled corticosteroid.
correct.
Probably. Okay.
And PRN ICS, and why is the latter step 2, and which ICS is the symptom-driven one?
Okay. All right. So you're asking about something that I really don't think you're going to see on your exam because it's brand new. You know, I used to work in a pediatric asthma clinic, and so I learned a lot about asthma, and I love this disease. I love treating it because when patients feel well and they breathe, they're happy patients, and you're going to know just like I do, happy patients make you a happy provider. So when we think about asthma, there was a 12-year study that was done and the results were just released. It is going to change the way you and I treat asthma for the next probably 10 years. It was a big deal, but it's too new to be on your exam. So as you approach a question in a patient with asthma, If someone has intermittent asthma, which would require a PRN medication, you're going to use a SABA, a short-acting beta agonist. We're not going to use an inhaled steroid. That's what we're going to do when the new guidelines come out. That's what we're going to do when the FDA approves Symbicort for that reason. But for right now, I know that I mentioned it in the video. I wanted you to be up to date because a lot of people come to this course for their continuing education. So we do use inhaled corticosteroids, ICS, PRN, but you won't see that on your exam. And to be honest with you, because the FDA hasn't approved the medication's use in that modality, and because the guidelines haven't been developed, I wouldn't be doing that in my clinical practice either. You know, if something happens with the patient, you need some evidence-based guideline to, you know, reflect why you did it. So PRN, ICS, don't worry about that for your exam. If someone needs a PRN medication, a short-acting beta agonist like albuterol is your go-to med. Did that get it, Kathy?
I think so.
Dr. Kathy?
Mary, let us know if that wasn't, she said thank you.
Okay,
Thank you,
so
Dr.
hopefully that got it. All right.
So just let me stop for a minute. And if you have a question for Dr. Amelie or Dr. Mimi, please use the Q&A. I am monitoring the chat feature, but sometimes there's a lot of activity in the chat, and I'm afraid that I will miss your question if you pose it in the chat feature. So if you have a question for Dr. Amelie or Dr. Mimi, please use the Q&A tab on your menu bar. That makes it a whole lot easier for me to make sure I don't miss your question. Okay. So one person said, you talked about respiratory quinolones, Dr. Amelie, especially Levaquin. Okay. How about Cipro? Is Cipro considered a GU quinolone?
Okay, so when we think of how quinolones were developed, they were developed by generations. And ciprofloxacin is considered to be a second generation quinolone, which means it's one of the oldest on the market. And when quinolones were first developed, they were used to treat urinary tract infections and GI infections. And that's the best use for Cipro. Cipro used to have efficacy against strep pneumo a long time ago, but it doesn't anymore. And so it's no longer considered to be a respiratory quinolone. Consequently, when we talk about quinolones to treat pneumonia, we never mention Cipro because it doesn't have coverage of strep pneumo, very poor coverage, and it really doesn't even have good coverage against the atypical pathogens that young, healthy patients would be more likely to have. Something like mycoplasma, you know, which is also called walking pneumonia. So Cipro doesn't even do a good job of treating that anymore. And so because of that, Cipro has kind of lost its designation as a respiratory quinolone. So hopefully that helps. Dr. Kathy, read the question one more time. I want to make sure I got it.
So yeah, she just wanted to know, why Cipro considered a GU quinolone? Yeah,
because of it's lost its ability to kill respiratory pathogens. It is an excellent choice for treatment of gut bugs and UTIs. In fact, this afternoon, when we talk about GI things, you're going to hear me talk about diverticulitis. And you probably know that when a patient has a flare of diverticulitis, we hit them with 2 antibiotics at one time, and one of them is going to be Cipro. So you'll hear Cipro again used in the context of treating a gut bug. So hopefully that helps.
I think so. And that was from Jury. Thank you, Jury.
All right.
Okay, so here's one from Sarah. Sarah says, can you comment about the recall or warning on Singulair and asthma treatment, and will that be included on the exam?
It's good question. Singulair is it got another black box, or its first black box warning just in the last month or so from the FDA. And so Singulair has, you know, you need to be more careful when you use it. Because it's generic, a lot of people use it. And that information is way too new to be on the exam. Because remember, information has to be out about 1.5 or 2 years before it finally makes it to your exam. And another thought that I'm having while you're talking about that is that, you know, part of the arrangement of the questions on your exam, there are always questions on there about safety issues. And so the safety issues don't so much deal with a recall or a new black box warning. The safety issues involve drug-drug interactions and drug-disease interactions. So a drug-drug interaction, you know, would be to give a Quinolone and I'm even drawing a blank, Quinolone and an antacid. That would be a drug-drug interaction. An example of a drug-disease interaction would be to give a Quinolone to somebody who has underlying cardiac issues that involve QT interval prolongation. That's a disease that a Quinolone would not be good with. A better one in the context of pulmonary is to give a COPDer a beta blocker. That wouldn't be a good idea because remember the beta receptors? You want the beta agonist in there to cause bronchodilation. And if you put a beta blocker in that receptor site, that's an example of a drug-disease interaction. So don't worry about Singulab being on your exam. And, you know, again, too new to be on your exam. But you sound like you're going to be a very astute practitioner because you're already reading all the latest information.
That's great.
Yeah.
Sarah said, thank you so much for answering that.
Oh, Sarah, it's my pleasure. And I hope that you're able to benefit from this format. Send Dr. Kathy an email and let us know if these questions, you feel like we're reaching you and getting these questions answered. So Dr. Mimi, let me ask you a quick question. How are y'all doing with COVID-19 on Cape Cod?
Cape Cod doesn't seem to be isn't really blowing up, but everybody is hunkered down. But again, we don't have a lot of testing going on. So who knows what the situation is really. Yeah. But people are heeding all the warnings and being really good about pretty much staying home.
Yeah,
everything's closed up. They even have elder hours at the grocery store, 6:30 to 7:30, so you can stay away from the crowds. We have that
here in Lafayette, which is in South Louisiana. We have that here as well. And so
it shows me a curve. I went to the pharmacy this morning to renew my EpiPen that I used at the conference.
Oh yeah.
And I did drive-through because I didn't want to go into the pharmacy because I figured that's where sick people are. And I felt like a sloucher that was going through the drive-in because I like my exercise.
Yeah.
It was kind of funny.
So, well, thanks. And I brought up COVID-19 because while you're kind of self-quarantined, obviously you're going out to work, but use this time to kind of help with your study. And I threw something out to you a little bit earlier about watching these and making notes about things that you need to go back and study, because we might be, you know, our activities are probably going to be curtailed for a while. And while that's not great, I think it's a great opportunity for you to be able to study.
Totally.
Yeah, it's totally a good idea. Yeah. So, I mean, you got to use your time somehow, and I'm using it to make more presentations. So.
Right on.
All right. Dr. Kathy, what else are people asking questions about?
We have a couple more here. Megan asked, during your review of bronchitis, you discussed indications for a chest x-ray. Cough and fever alone were not an indication for a chest x-ray in bronchitis. However, in asthma, cough and fever are indications for a chest x-ray. And so she's asking, can you clarify that? She's wanting to make sure she's not misunderstanding.
Okay. Cough and fever. So I'm thinking back to acute bronchitis, and I'm thinking back to, you're probably referring to the slide that asks about when should you consider a chest x-ray. And it's always with an acute cough and a change in vital signs. So with acute bronchitis, people don't usually run fever. And I would think fever means a temperature greater than 100.4. As long as the patient has an acute cough and they're not running fever, I hate to throw out a number, but you know, as long as it's less than 100 and all the symptoms look like acute bronchitis, I'm not so apt to jump into getting a chest x-ray. unless they're older, unless they're fever, they're running fever, or they have an increase in respiratory rate. And that increase in respiratory rate, especially if they're an older adult. If you're thinking pneumonia because your auscultation indicates either consolidation or maybe rales, then I would get a chest x-ray. So I think you have to use your good judgment. And the point I'm trying to make, especially for your exam, is to make sure that you don't just get a chest x-ray because somebody comes in with a cough. They have to have something else going on with them that makes you think that they may have pneumonia. And that would be the reason for your chest x-ray. So hopefully that answered your question. And if I could ask where you work, because I'm thinking that, I don't know if we can get a response back that quickly, Dr. Kathy, but
sure.
If you work in the ER, I know what your brain is thinking. And a lot of people who work in the ER think, when a patient comes in, a cough, boom, they get a chest x-ray, just because that's the nature of emergency medicine. But honestly, in primary care, and remember you're taking a primary care exam, in primary care, when a patient comes in with a cough, we always look for especially a change in vital signs before we jump to
Right.
a chest x-ray.
She said she works in the ED.
I had a feeling. So listen, here's a great piece of advice for you and anybody else who works in a specialty area. Remember, you are going in to take a primary care exam. So when you go in to take this exam, take off your specialty hat, like the ER hat, and put on your primary care hat. All right. So I had a feeling you got to make sure that as you answer the questions on this exam, that you answer and think like a brand new NP, because this is an entry-level exam. So think like a new NP, somebody who's just out of school. The exam is going to measure what you need to know coming out of school, not what you're going to know after a year or 5 years in practice. So hopefully that helps. What else are they asking about, Dr.
Well, I'm gonna ask this question. I'm kind of out of order, but I think it tags on to what you were just talking about.
Okay.
And she said, Sarah says, what if your diagnosis is influenza? So you have an acute cough, you have fever, but it may possibly be a pneumonia. What about that situation and the chest x-ray?
In that situation, certainly you have to get a chest x-ray, because probably remember that the number one sequela, the most common sequela of influenza is pneumonia. So if you suspect pneumonia from the clinical presentation of the patient, don't hesitate to get a chest x-ray. And in fact, we're dealing so much right now with COVID-19. And you know that one of the things that is landing people in critical care units and on ventilators is the pneumonia that follows COVID-19. So those viral infections can really be a precipitant for a serious sequela. With influenza, it's pneumonia. With COVID-19, apparently it's pneumonia. So if your gut tells you that that patient may have a pneumonia based on their clinical presentation or an abnormal auscultation, by all means, get a chest x-ray.
While you're there, Dr. Amelie, why don't you clarify about the cough? And so if you have a patient who comes in with influenza, and you don't get a chest x-ray that day because you do have influenza, when would you likely get a chest x-ray based on the cough presentation?
Well, as you come in and you're diagnosed with influenza and probably treated with one of the antiviral medications, you may not get better for the first 24 or even 48 hours. But after that time, you should do nothing but get better and get better. If somebody was not getting better after that point, you certainly need to consider a chest x-ray. So I don't want you to hesitate in getting one when the clinical presentation suggests getting a chest x-ray. What I want to make sure that you don't do, especially not just on the exam, but in your practice as well, is just routinely get a chest x-ray if the patient doesn't have something besides just a cough. And sometimes just a cough will be it, but it all kind of goes into development of your clinical judgment. And Dr. Kathy, do you have anything to add about that?
Yeah, and I agree with Dr. Amelie. It depends on the presentation of your patient. And I know that you guys are worried about exam. And I know that if you're going to have a question asking you when to get a chest x-ray, there's going to be some keyword in there that is going to help you determine whether you need to get a chest x-ray on that person. And it may be that the cough has lasted for several weeks and is not improving, or that they have a comorbidity like asthma or COPD, because those individuals are going to be a little bit differently to be treated than just a 25-year-old that's healthy that comes in with a fever and a cough. So there's going to be something in the stem of that question that will help you determine if obtaining a chest x-ray is going to be the right answer for that.
Yeah.
And in the clinical setting, obviously, like Dr. Amelie said, you're always going to use your best judgment, and you have that still small voice that's going to say, gosh, you need to get that chest x-ray, and you're going to do it.
Mhm.
Yeah, it's Kathy, that's sage advice. And I'll bet you that Dr. Mimi will tell you the same thing.
Totally.
If you go home or you take a patient home with you,
Yep.
Mimi, can you expound on that a little bit?
Well, I always, if you're spending a lot of time worrying about your patient, usually that indicates that you need to potentially reevaluate them, make sure they're doing okay, and maybe they have some change in their condition that now renders a different approach.
Yeah, it's just sage advice. And I think you got probably 100 years worth of NP experience from the three of us who all kind of said the same thing. If something inside of you lets you know it's more than just a cough, you have to take the next step. So,
And I've always sort of taken on the habit of any patient that I saw that I was really worried about, I would always check with them the next day, sometimes even that evening after clinic, and make sure that they're doing okay. And that has just served me really well, and I think patients really well over.
yeah.
Absolutely.
You know what else I find? I do the same thing, Dr. Mimi, and I'll tell you this. It did two things for me, especially as a new NP. It allowed me to learn a lot about my patient and the cause of the illness. That's how you learn. You follow up with these people, and then you get to know, oh, this is how this disease progresses. So it taught me a lot by following up with a phone call. But the other thing is it helped me sleep at nighttime.
Exactly.
Because I didn't have to worry about a patient going bad. They came in, they got worse, and I didn't,
And it's great for customer service. It means so much to a patient.
When they get a call, of course it does.
Very personal.
Oh, absolutely. So,
and remember, we're always ambassadors for our profession. So anything you can do to enhance the perception of the patient and provide quality care, it's a win-win.
Yeah.
So Dr. Mimi, Sarah wants to know, how would this situation apply to a pregnant patient?
Well, there's not much we give to pregnant patients, so we would have to be very, very careful. And we have basically ampicillin, amoxicillin, Keflex, Augmentin,
and really
not a lot
even
of choices.
Macrolide.
Right.
And while we're talking about pregnant patients, we talked about pneumonia. So remember, no tetracyclines in pregnant patients.
And why is that? You should know. Why is that? We don't want to discolor the baby's teeth.
Tooth enamel, exactly.
And that could be fair game on the exam, right, Amelie?
Oh, that's a good exam question. Woo! So tetracyclines, and the other antibiotic that we do not want to put in a pregnant patient are the quinolones that we talked about. And the reason for that is that, remember, the quinolones can impair bone and cartilage formation.
Right.
Because we have a developing fetus, that's the last thing we want to go on.
Yes.
So that's a great question. We've spent a lot of time talking about pulmonary, and I'll spend the rest of the time talking about it. But does anybody have any questions about
hematology? We have one more question on pulmonary, and then we have some GI questions and a CBC question for you.
Oh, good. Okay, good.
So Mary says, and this is the last respiratory question. In the video, no fever and cough, the differential was TB. Can you explain what signs and symptoms to expect TB? I thought fever was one of them.
TB is one of those diseases that often is, listen to the term, occult, meaning it hides. So the vast majority of patients who have TB have no symptoms, and they're either picked up on a screening, but sometimes their presentation is just a cough. And I don't mean just a cough, but a cough is the only symptom that they have. Sometimes it's night sweats, but I think if you look at most common presentation, it's cough, and it is usually not fever. However, fever can accompany cough in patients who have TB, especially if they are older, they have other comorbids, especially if they're diabetic. So when you think of someone who may be compromised because of either their age or disease, or maybe a drug they take compromises them, they may be more likely to run fever. But the typical presentation of TB is not one with fever outside of a population that is, impaired because of their age, or they're compromised in some way. So hopefully that helps.
Okay, and I may have been mistaken about that respiratory stuff. So there's a couple more questions.
Kathy, you're allowed one mistake a day, and
Okay,
I
good.
made one in a while, so you're good to go.
So Mary says, you mentioned we don't need to know the exact name of medication in the combo asthma medication. Should we know if they contain a LABA, ICS, etc.?
I'll be honest with you. Most of the exam doesn't ask you about the combination meds, in the asthma meds like Advair, fluticasone, and salmeterol. They're not going to ask you, which LABA and which steroid is in there. But if they speak about an asthma combo medication, they want to make sure that you realize that a combo in asthma means a LABA and it means a steroid. And to be honest with you, I get a tremendous amount of feedback from people who've taken this course and then who take the exam. And I just don't hear a lot of people asking or telling me that they got questions asked about asthma combo meds. So maybe that'll make you feel better.
Thank you. Jamie says, for inhaled anticholinergics for COPD, you said they can cause problems with cognition in the elderly. Is there an alternative to these meds for COPD control for someone who is having cognition issues?
Yeah, let me kind of tell you one of my favorite stories, and I don't think I said this in the video, but if I did, forgive me. I remember having an older patient with COPD. She was probably about 82, and I had done with her what I could do with her, and I sent her to pulmonology. I didn't know when she had an appointment, but about 10 days or so after I had seen her, her family member called and said, Amelie, something is wrong with Mama. And I said, what's going on with Mama? And she tells me, she said, look, Mama used to be independent. She did well. She lived alone. But all of a sudden, Mama is driving up into the neighbor's driveway and she thinks that's her house. And she's telling me that her front door key doesn't work anymore because Mama was at the wrong house. So I said, well, bring Mama in. And the first question I asked, because you always do this with older adults, is, are there any new medications this lady is on? She had seen the pulmonologist and she had received a prescription for Spiriva, which is an inhaled anticholinergic. And older adults can be very, very sensitive to that. So the minute I heard that, I thought that was probably the medication that did it. And I picked up the phone as a professional courtesy, and you ought to do it too. And I called the pulmonary office. I told them who I was, and I asked to speak to the doc, and his NP came on. And I told her what was going on, and she said, oh, by all means, go ahead and stop the Spiriva. So if you remember the prescribing strategy for COPDers, when you give a long-acting anticholinergic, if you can't give that because the patient's not tolerating it, the alternative is a long-acting beta agonist. So something like salmeterol. Remember, it ends in terol, so it's a beta agonist. Salmeterol is a long-acting beta agonist, which is exactly what we put this lady on. So we stopped the Spiriva, we started the LABA, and after about 4 or 5 days, she began to park her car at her house again, and she was happy to say that her front door key started working again. So, so as an alternative to a long-acting anticholinergic for a COPD, I would give a long-acting beta agonist. And sometimes you could give a short-acting anticholinergic along with a beta agonist. You kind of have to fool around with the meds and see what they do well with. But watch anticholinergics in older adults, because some of them are very, very sensitive, and they just don't do well with it. So hopefully that helps and gives you an alternative.
Okay, so this next one from Jury Lee, and says, thank you for all the answers. This is awesome. So that's good feedback. We appreciate that, because this is not optimal. And so we were a little worried. So we appreciate that feedback. The question is, what would you prescribe for a geriatric patient who has AFib and bad gastric esophageal reflux disease, and they came in for acute bronchitis?
Okay, so they come in with acute bronchitis. It's a geriatric patient, and she's got AFib, atrial fibrillation. Okay, and she's got bad reflux.
Correct.
Okay, so when I think about acute bronchitis, the first thing I think about is that it's probably viral, and a little TLC might go a long way. But your patients are going to be just like mine. They feel like they gave you their money. They want something for their money. I wouldn't give her an antibiotic necessarily unless I thought it was a bacterial infection. And I know with acute bronchitis, it's probably not. If she's got bad reflux, something hits me. The reason acute bronchitis patients come in to see you is because they cough and they want relief. So I like to give Tessalon pearls. However, if she's got reflux disease and it's bad, I wouldn't even consider giving her a Tessalon pearl. The mechanism of action of those little gold jelly beans is that it is an anesthetic, and it anesthetizes those little irritable parts of the respiratory pathway. But if she refluxes that, she may get an anesthetic effect in the back of the throat. So I don't like that at all. I don't like when people can't manage their own airways and their GI tract. So I wouldn't consider a Tessalon pearl in her. I would question giving her any medication, but if she really pushed me, I'd give her dextromethorphan. And if you want to keep her busy, okay, that's kind of a joke. You want to keep her busy, give her an every 4 to 6 hour Robitussin, DM. If she doesn't need to be kept that busy, you could give her plain old Delsim, which is just plain old dextromethorphan, and the activity is about 8 hours. So it works, she wouldn't have to take it quite as often. And I would probably just remind her that what she has is going to go away. And I might have missed the significance of the AFib.
So, so the second part of that, and I think that's a very good answer, because that's exactly what I would do too. But if you thought that you needed to give an antibiotic for some reason, the question goes on to say a Z-Pak is contraindicated because of the irregular heart rate, rhythm, and doxycycline can cause esophageal irritation. So what would you think if you needed to give an antibiotic?
The first thing you always consider when you think about what antibiotic do I need to give, the first question you have to answer is always, what bug am I treating? So what bug do you think you're treating with acute bronchitis? If it's bacterial and it's not Bordetella pertussis, because that's the #1 reason people have acute bronchitis, secondary to pertussis if it's bacterial. The other bug you have to consider is strep pneumo. And in that case, I'm going to give her high-dose penicillin. And I probably will follow the new pneumonia guidelines for acute bronchitis. I would probably give 1 gram 3 times a day of amoxicillin. And if the patient was a smoker and H. flu was the bug, what would you give, Dr. Kathy? I don't know if I'd be
Amelie.
afraid with a macrolide with atrial fib, but if there's any QT interval prolongation, I wouldn't even consider a macrolide, and certainly not a quinolone.
No, and those are safety considerations. But and you need to know that for the medications. Does it mean that you absolutely would not give it to someone? No. If that's the best treatment choice, then that might be what you do. And you just make sure that you have supports in place for that patient. Doxycycline, if I felt like doxycycline was going to be the best course of action for that patient, that's what I might do, because you also have to weigh the risk versus the benefits. And I would make sure that they have medications on board to help with the reflux if I was concerned with that. So, you know, you can always if, and but, as one of my professors used to say, yourself to death, but you have to do what's best for the patient, considering the safety and considering the risk. We certainly don't want them to get into trouble with a bronchitis that we're not treating appropriately. So.
Okay, good.
Okay, so are we good? I think we're good on those.
Hey, Dr. Amelie.
Yes, yes.
There won't be any coronavirus or COVID questions on the exam. I think people need to remember that.
Yes, COVID-19 is way too new for your exam. And so I know you won't see any questions about that.
But it's definitely in our thinking as we think about these cases. It's really incredible.
It has
and
to.
I think that no one knows a lot about what's going to happen with it. So nobody even really kind of knows how to write a question on it at this point.
Yeah, exactly.
All right.
Okay, so this is from Beverly.
Okay.
Beverly says, Dr. Amelie, the CBC interpretation where it showed leukopenia,
Okay.
macrocytic, normocytic anemia, the poly and the lymphs are close together, mono is high, think viral. You said to get B12 folate levels. Would this be an alcoholic and or a malnourished person?
Okay, run those things by me again, Dr. Kathy.
Yeah, there was a lot there.
Yeah, give it to me again.
Leukopenia.
Okay.
Macrocytic, normocytic.
Macrocytic, normocytic. So in my differential right away, I'm thinking B12 folate deficiency.
Yep.
Okay.
Right. Poly and lymphs are close together. So the mono is high, think viral.
Okay, wait, those are two different.
There are multiple different, yeah. Beverly, maybe you could break those into different questions if you don't mind.
Well, I'll decide it right now, Kathy.
Okay.
So if the patient, there's two things going on with this CBC, and I really don't know which one you're referring to, but if somebody's got polys and lymphs that are close together numerically, I want you to always think viral, all right? So the polys and lymphs move in one direction or the other within 2 hours of your getting sick. Whether it's viral or bacterial, they go up, they go down. So polys and lymphs are to be thought of as your first responders. They move the minute you get sick. If the polys and lymphs are close together numerically, think viral. The monos are another white blood cell. In fact, it's a great white blood cell, but it doesn't come to help you when you get sick for at least 24 hours. So if the monos are elevated and the polys and lymphs are close together, I'm thinking viral because of the polys and lymphs. And if the monos are are elevated, I'm thinking the patient's been sick longer than 24 hours. So those are three different white cells. The polys and lymphs tell you whether you should be thinking viral or bacterial. The monos tell you how long the patient has been sick. So two different concepts, and hopefully that helps kind of split them up. And then as far as the macrocytic normochromic anemia, because it's macrocytic in my differential, I'm thinking B12 and folate. And remember, those are the two little thugs, as I like to call them. Those are the two little thugs that run together. So when you check a B12 level, always check a folate level as well, all right? And sometimes patients have both anemias at the same time, and if you only treat one, the one you're treating will never get better if you haven't treated the other one. So always check a B12 and folate level together. And remember, both of them represent vitamin deficiencies that produce this macrocytic anemia.
So this one's kind of a general question. Megan says, might be a little off topic. Should we approach this review course differently if we're taking the ANCC versus the AANP certification exam?
I don't know that I would approach it any differently, and I can give you an evidence-based answer. The evidence-based answer is people who take ANCC's exam and AANP's exam have the same exact pass rate with this course. It's a 99% pass rate. Heck, Kathy, you could speak to this better than I can, but people who take this course the first time do equally well, whether it's ANCC or AANP. So I don't know that I would approach it any differently. However, whichever exam you decide to take, I would make certain that I went to that certifying body's exam blueprint page. There's going to be an exam blueprint. Make sure you go and look it over for ANCC's exam, and make sure you look over the blueprint for AANP's exam. Now, I know you wish it was more enlightening than it really is. It's not going to say 5 CV questions and 2 on derm, and it doesn't tell you that, but it gives you kind of an idea of what you'll be asked about. And what you're going to find when you look at the 2 exam blueprints is that AANP's exam blueprint is 100% clinically based. ANCC's is almost 100% clinically based, but I want to pass on some information that I'm getting as feedback from exam takers. And they tell me ANCC's exam has some questions on it that are research oriented. So they ask questions about randomized clinical trials. I'm still getting that even with the new exam blueprint that changed at the end of 2019. So check out the exam blueprints, but the information in this review course, I think, will prepare you adequately regardless of which exam you take. Kathy, do you have anything else to add about that? Kathy is psychometrics, which is numbers and exam questions and things.
Right. And so I do help students develop study plans, and ANCC changed their exam blueprint this past year. So I do encourage you to look over that. We do have supplemental information in the packet that you get on the CE Center to help you with some of those role questions. So certainly look over that information. And if you don't know where your weak areas are, I would encourage you to take a predictor exam, because that's really going to help you to hone in on what you need to review in order to prepare for the certification exam.
I'm glad you brought that up, Kathy. We haven't really had a lot of questions. We haven't had any questions yet about how to prepare for the exam. But I think you should, get at least get more than pulmonary and hematology under your belt. I would watch a few of these videos. But what we have is a page set up, and there's a link in the email that you got. And the link will take you to a page that gives you a discount on products to help you prepare for the exam and take into your clinical practice. And you'll get the same exact discount that you would have gotten at a live course, and of course we'll free ship it to you. So maybe either later tonight on our second session today, or sometime tomorrow, if you have questions about the exam, we will happily answer them, and we'll be happy to do that. But we'll kind of give you some guidance too, if you ask, on what products would help you best prepare for the exam. We're happy to do that. I always tell people, I want to make sure you're successful on this exam, and I am going to do everything that I can to make sure that that happens. So ask me questions if there's something that we missed, or you just need a little more tweaking on. Don't hesitate to ask it. I've never heard a stupid question.
Ever. We're all here for you.
Exactly. So, we want you to be successful.
Hey, guess what, Amelie?
What, Mimi?
There's a FedEx truck here. I think maybe it's my jersey I ordered from the Super Bowl. I'm so excited.
All right, Mimi. I heard that COVID-19 can live on cardboard for a little while. So
I know, 24 hours.
When you get that package, 4 hours.
We had gloves on.
Okay, good.
Okay,
She's the queen of antibacterial wipes.
I am. I'm a freak.
So Dr. Mimi, Sarah has a question for you.
I see
She
that.
said, can you provide some tips to help calm my fears about pregnancy, not limited to and including recognizing what meds are safe in pregnancy for chronic medical conditions? Some are safe in the first versus last trimester, third, not first. Can you give her some pointers about that?
Well, Sarah, I don't know how many, thank you for asking the question. I don't know how many medications and pregnancy questions would be on the exam. Amelie, do you have any idea?
I mean, I really don't. Sometimes they get sprinkled in among material that you wouldn't even think was about a pregnant patient.
All right. So the basic concept with pregnancy is less is more. And generally older medications versus newer medications, just in concept. We know that certain medications are safe in pregnancy. At least we think we know that they're safe, such as insulin and metformin and levothyroxine. Now, those are all, we think, pretty safe. Now, when we get into antibiotics, that's all changing, and some other very common medications, it's changing even with Tylenol, which just in the past year, year and a half has been linked to possible behavioral problems in offspring. We used to think that nitrofurantoin, better known as macrobid, was safe in pregnancy, but now there's a warning to avoid it in first trimester. So my message to you is that you need to just think about older medications and think about a question that was developed about a year and a half to 2 years ago. So some of this late breaking information I'm sharing with you will not be on the exam. For example, nitrofurantoin, macrobid, they may ask you if that's safe in pregnancy, and your answer is going to be yes, because the new information hasn't been out very long, warning against first trimester. Right, Amelie?
Yeah, and I think they're more likely to make sure that you want to know that doxy is never a good choice.
Right, so doxy is like a big question.
Never a good choice. Yeah.
The fluoroquinolones, huge. We don't give those to pregnant women, so that would be another question possibly. Fair game on the exam, Amelie?
Yeah. Yeah.
Yeah.
And more,
So think about what they're going to look to see if you're going to be a basic safe practitioner in that first year. They're not going to be looking at shades of gray, and they're certainly not going to have an exam question on anything that's relatively new.
right.
And I think on a family exam or an adult gero exam, you know, there's probably just a few diagnoses that you would need to be aware of as far as the medications. And that would be depression, anxiety, because you likely have an SSRI.
So the SSRI that's the safest in pregnancy is sertraline, better known as?
Zoloft.
Zoloft, right.
I thought maybe you were wanting them to answer. I'm like, how are they going to do that?
I know, I was just pausing.
So that would be a diagnosis that you would need to be aware of that medication. Hypertension, diabetes, and hypothyroidism, I think, are probably some of the top diagnoses that you would see a pregnancy question on a family or an adult gero exam.
Yeah,
but I don't think that they would.
I mean, one of the reasons we do urine cultures in pregnant women before we treat them is to make sure we have a match with the antibiotic and the organism, because we don't have many antibiotics we can utilize. Keflex, penicillin, ampicillin, amoxicillin, and we don't have a million choices. Nitrofurantoin after the first trimester.
And because if it progresses, it gets worse, it can precipitate
Preterm labor.
Yay!
That's always our concern in pregnancy. That's why women that are pregnant never get in and out of an office for any reason without peeing in a cup.
Yep.
That's right.
Yep.
Okay.
Thanks for that question, though.
Yeah,
Sarah.
good question.
Good question.
Got some really great inquiring questions.
Very good. So Megan says, with antibiotic treatment, you say treat based on the bug. Without a sputum culture, how do you determine what bug to treat?
What a great question, because guess what? Just as we had with the old guidelines, the brand new guidelines are reinforced for outpatients with community-acquired pneumonia to not get a sputum specimen. You know what? If your background is a hospital, when the patient with pneumonia hits the hospital or an ER, they get a sputum specimen and then they get an antibiotic. But for outpatients, they want you to profile the patient or treat them empirically. So if they're older and have comorbids, or they're immunocompromised regardless of their age, or they've had recent antibiotic exposure, you give them a respiratory Quinolone first line. If they're young and otherwise healthy, non-smoker, we give them a macrolide or doxy, and with the new guidelines, amoxicillin. So you kind of treat according to where they fit. And so, so we don't get sputums anymore, and actually we didn't in outpatients.
And I don't know if you guys have seen it or not, but there's a lot of infections that we usually do treat empirically. And so Dr. Amelie has created some antibiotic reference cards, and they are phenomenal to help you know what the common organisms are per diagnosis. So if it's a urinary tract infection, otitis externa, whatever, and to help you guide you in the antibiotic choice selection based on what the most common organisms might be. So if you're treating them empirically.
Yeah.
So you don't give Levaquin to everybody, right?
Right.
Right, Mimi.
You know, I'll just kind of have an aside for just a second. The antibiotic cards, and I'm glad you brought them up, Kathy, because I feel an immense amount of pride about them. But I developed those things 22 years ago, and they've had obviously multiple iterations as things have been updated, and they were just updated again. But to be honest with you, 22 years ago, there were so many people in one class that I taught, and I don't even remember where I was. So many people were confused with antibiotics. I realized, my goodness, if you're confused, then so is the rest of the NP population. And those cards have just been one of our best products for 22 plus years. So if you're confused about antibiotics or you have questions, it's because everybody does. And, you know, I hate to put in a plug, but I think those cards would help you. So
And they fit in your lab pocket just perfectly.
Well, I put in
Your
the
lab
plug
coat
because I
pocket.
did use them as a student and the first year out of practice, and it helped me immensely. So I do think it's a very valuable product to have in your pocket when you're out there treating patients. So.
I didn't even know that, Kathy.
I did.
I didn't know that. Okay.
Sweet.
That's been 11 years ago, but yeah,
Wow.
I remember it like it was yesterday, kind of like PTSD.
Hey, Amelie, you hadn't written them yet when I started. I think you
Well, I
were
know,
barely
Mimi,
born.
Man, I wasn't born when you started.
That's what I just said. Don't rub it in.
No, actually, I was born, but I don't think I was in high school yet.
No, I don't think so.
All right.
So let's see.
I'm looking at the time. I guess we can answer another question. We could save them for this evening. I don't want people to get off schedule too much. So,
No.
and Mimi teases me all the time and says, you know, I run on atomic time. So
You do. Absolutely.
Okay, so let's see. So 2 more. Y'all want to do 2 more?
sure.
Okay. German, I hope I said that name right. Do you recommend taking the proctor exams after we have completed our studying and review for the exam, or while we are preparing? So you're meaning predictor exams?
I think that's what she means.
I think so.
I think, and maybe tonight we can talk some more about the exam, but I think you should go through the review, check all the things that need more study time by you, make a list, and study the things on your list. After you feel like you've studied things, then is the best time to take a predictor exam. So you can kind of find out where you are. The reason we develop those predictor exams is so that you can kind of get a feel for, do I know enough to go take this exam? Because you only want to take it once. I mean, you just want to take it once. So I would wait until I had studied and I felt pretty well prepared before I took one. You know, as part of this course, you're going to get 2 100 question, question sets that you can, you know, practice questions with. We have Q banks that allow you to practice questions, but those predictor exams are statistically predictive. That's part of what Dr. Kathy does. I mean, she's a number whiz, and so she's the person who crunches all those numbers. Kathy, when do you tell people to take a predictor exam?
So I usually do tell them to take it after they've done the review course, and certainly at least 2 to 3 weeks before you're ready to take your certification exam.
Yeah.
And so that's going to, again, and maybe I'll have a sample of the report pulled up for you this evening to kind of give you an idea, but it shows you exactly where your weak areas are that you need to review. And you always need to allow yourself at least 2 to 3 weeks to review those areas before you go take your certification exam.
Yeah. Kathy, that would probably be really good for us to start off our evening,
Sure.
our session this evening with. I think that would be real good. And if you could talk about it, because my goodness, Kathy knows this stuff intimately. Mimi does as well, because Mimi just knows a little bit of everything. What's the second question, Kathy?
Okay, so let me filter through this just a second here. So Dr. Mimi, Sarah says, women's health is another one of my scary topics. I've been stumbling over oral contraceptives. Can you give her some guidelines for that?
Well, Sarah, you're going to be watching our video, my video on women's health, and I'll tell you a little bit about contraception in that. Also, I highly recommend you download and utilize the app from the CDC on contraception. So it's CDC Contraception 2015.
Yeah, it's
I believe 2015. And so make sure that you're guided by those guidelines, which if you have the app, they're updated on a continuous basis. If you go to the website, the same thing. If they're printed off at a certain point in time, you won't have the benefit of the updates that they produce. So I think that you have to be evidence-based, and a lot has changed. So it's not something that you're just gonna be able to memorize, except some of what you a lot of.
Okay, great. So does that cover our most burning questions?
It does. It does. Beverly, if you are listening, can you please pose that question, maybe even send it in questions to APEA, and we'll make sure that we look that up in page 12, and we'll address that this afternoon at the later session today. There were a few more questions about predictor exams, and we will talk about that at length this evening as well.
Yeah, that'll be great. And listen, just if you hear, or maybe you joined us late, these sessions, these live talks like this will be recorded, and we'll send that to you so that if you missed something, you'll be able to get to it. So anyway, this was fun, and I hope you found it helpful.
It was fun.
It was. So I would say let's wrap it up right now. Let's reconvene. And this afternoon, what time, Kathy? I know it's 6 Central, 7 Eastern.
Central time.
7 Eastern.
Okay.
I'm not sure what time is it in Arizona. I always get a little confused about Arizona.
It's like 5 o'clock, isn't it? I don't know. It's mountain time, whatever that is.
4 p.m. 4 p.m. Arizona
4 p.m.
time.
Okay.
4 p.m. Arizona time. Okay, that's good.
Good luck, everybody, watching the videos.
All right. Thank you for being with us. I'll see you tonight.
Thanks, Amelie and Kathy and team.
All right. Good job, everybody. Bye-bye.